Good morning all. Today we are going to see about the condition birth asphyxia. First I wish to say what is my birth asphyxia. Birth asphyxia is a medical condition resulting from deprivation of oxygen to a newborn infant that lost long enough during the birth process to cause physical harm, usually the brain. So here in other word, birth asphyxia is simply defined as to the failure to initiate the sustained breathing at birth. So here the babies can't able to breathe normal. Here the oxygen a proper amount of oxygen they can't get for breathing. Here oxygen level is decreased and carbon dioxide levels may be increased in the blood, so the baby is not able to breathe normal. So this condition is called as the birth asphyxia. Next I wish to say the definition of birth asphyxia. According to the WHO organization, birth asphyxia is defined as a failure to initiate sustained breathing at birth. And these type of children they can't able to breathe normal as like us. Here they have the breathing they failure in breathing. So next classification of asphyxia. Asphyxia will be classified in three types. So first one is the mild birth asphyxia, moderate birth asphyxia and severe birth asphyxia. In mild birth asphyxia, the children is having the symptoms like hyper alert, poor feeding, normal and fast breathing symptoms at least for the 24 to 48 hours. Next, moderate asphyxia, the children is having look like a mother, maybe the lethargic, but they have the symptoms like feeding difficulty, occasional episodes of apnea and then convulsion. In when we are seeing the severe birth asphyxia, the children just look like a floppy or unconsciousness. They can't take the feeding, frequent episodes of apnea and then convulsion. Here we need the treatment, we have to initiate the treatment very soon as possible. So these are the I think you people are understand about the classification of asphyxia. Next we move on the incidence of asphyxia. Here in Nigeria they did one study in that to 26,000 newborns, here to 864 children out they have the incidence of birth asphyxia. And next in Nepal, among 3,804 live birth, there is one or two babies with birth asphyxia. This is the incidence about the birth asphyxia. Next, etiology. Here, certain maternal factors that may cause the birth asphyxia in children. For example, if the mother is having the hypoxia, anemia, diabetic mellitus, hypertension, smoking, nephritis, heart disease, the mother is very young, old, these babies are only affected with this birth asphyxia. And next, certain placental umbilical conditions that may cause the birth asphyxia like abruptial placenta, placental previa, prolapse cord, premature rupture of the membrane, fetal maternal hemorrhage, umbilical cord compression, infection, inflammation in the umbilical cord. These are the conditions may cause the birth asphyxia in children. And then in some other condition, others is factors also cause like fetal factors like multiple births, congenital malformed fetus, and then severe cardiopulmonary diseases. These are the conditions that may cause the birth asphyxia. Next we move on the pathophysiology. As I said before, we know the factors that may trigger the severe hypoxia in the uterus. So here this hypoxia leads the loss of consciousness. So once they lost their consciousness, here the lack of oxygen supplies in the neurons. So here the fetus may experience the primary apnea. So here heart rate decrease, myocardium reverse then back, and then here lactic acids may release, respiration is reversed, and then cause the cardiac function is impaired, ventilation and oxygen compression is required. So here the if you are not giving timely intervention, the child may death can occur here. So apnea means there is cessation of breathing taking more than 20 to 30 seconds. I think people understand about the pathophysiology. Next, we are more on the signs and symptoms of birth asphyxia. Here, the children look like gray and bluish pale color baby. They have the weak breathing and the respiratory distress, a slow heart rate and weak pulse. weak pulse, poor muscle tone, acidosis is a dangerously high level of acid level in the blood, and then they may experience the seizure also. These are the signs and symptoms we can see in the children, those who having the birth asphyxia. Next we move on the diagnosis of the birth asphyxia. First, as we know the history collection, maternal, and we have to ask the mother whether they having any anemia history in the perinatal risk factors such as the asphyxia with the secondary apnea, neurological cardiac and renal protuberance, and then ABGAS score. We have to check the ABGAS score whether it is 510 minutes. We have to check the ABGAS score. So and next we have to do the physical examination. In the score is done the newborn 1 minute and then 5 minutes. The ABGAS score is related to the state of oxygenation of the fetus immediately after birth. So here I used to show the table column. So ABGAR, A stand for the appearance, P for the pulse, G for the cry mass, and then A for the activity, and then next R stand for the respiration. These are the ABGAR. So here we have to check the appearance, pulse, cry mass, and then grimace, respiration. These are the things we have to check in the ABGAS score. Here they were giving the score. In that score, total score is 10. If the baby is having the no asphyxia, their children are scoring 7 to 10. If they have children is having mild asphyxia, their score is around 4 to 6. And then if they have in the severe asphyxia, the children are getting 0 to 3 marks. So if the children is having 0 to 3 marks, it will indicate that the baby is having the severe asphyxia. We have to give the immediate medical attention, so then only we can save the patient's children's life. So next we are move on the laboratory evaluation of the asphyxia. Here we have to monitor the serum electrolytes, renal function test, cardiac and liver enzyme, coagulation system, ABG, arterial blood gas. These are the things we have to assess. In serum electrolytes, we have to monitor about the sodium, potassium level, chlorides level, whether the urine, if they having the secretion of SADH during the initial 2 to 3 days of life. And in renal function, we have to monitor about the creatinine level, blood urea nitrogen levels we have to monitor. In cardiac and liver function, we have to check the hypoxia and ischemic injuries in the other organs we have to check. And then when we are seeing the coagulation factors, we have to monitor about the prothrombin time, partial prothrombin times, and then fibrinogen level we have to monitor. In ABG we have to monitor. In next we are move on the management. First, I think we people know the types of asphyxia. Here we are treating the mild cases. First, allow the baby to begin breastfeeding. If the baby is receiving oxygen or otherwise cannot be breastfed, express breast milk can be given here. Provide ongoing care. We have to continue the care. So first we have to initiate the breastfeeding. If the baby is receiving the oxygen, we can't give the breastfeed. If we can initiate the bottle feeding for the babies. So next, in moderate and severe cases, treat breathing difficulty if present. If they have babies having the breathing difficulty or they experiencing any apnea, we have to initiate the resuscitation measures immediately. We have to take. If the baby is not breathing at all, even when stimulator, when we are giving, we have to start with the tactile stimulation. If the baby there is no stimulation after this, there is no response from the baby. If there is any gasping respiration is present, if the respiratory rate is less than 20 breath per minute, we have to initiate the cardiac resuscitative measures. We have to in between we have to monitor the history collection. We have to done for the patient, whether the baby, what is the term of the babies, whether what is the term gestation, whether the baby immediately crying after birth, what is is they having the good muscle tone. These are the things we have to do. If all the questions, if they are saying yes, there is no need the resuscitation. We have to check for the, we have to keep the babies in mother skin to skin contact. Then if there is no means, we have to start the CPR. So when we are giving the compression, we have to use the 2 finger method, and then here the picture is showing 2 finger method, and then 2 thumb methods also we are using here for the compression. During the chest compression, pressure should be applied the lower third of the sternum, and then depression will be 1/2 or 3/4 inch. We have to give the depression compression over the chest, and then we have to ventilate the baby after the 3 chest compressions. Do not do the chest compression and ventilation at the same time. First we have to initiate the chest compression, and then we have to ventilate the baby. About 30 compressions should be given 1 minute. We have to give within 1 minute we have to complete the 90 compressions, and then in 1 minute 30 ventilations and 90 compressions we have to provide here. Recheck the respiration and heart rate. If the heart rate is above 60 beats per minute, again repeat the cycle, ventilations and respiration and compression. Recheck the heart rate is above 60, stop the compression, and then we have to continue the CPR. I think you people know about the CPR. So next, if the heart rate is more than 100, if the baby is breathing its own, we have to stop the ventilation. If it is 60 means we have to continue the ventilation. If the baby is having above 100, we can stop the ventilation. Support the baby with the warm. Here the warm is very essential. Here the heat loss will be occur. So here we have to provide the warm oxygen stimulation. Oxygen stimulation until pink, and the babies become the normal color. So we have to check whether the baby is having the cyanosis or so. If the till the baby is having the cyanosis means there is the insufficient oxygen supply. So if the babies become pink, which may indicate the baby is okay. Stop the ventilation, just compression after the 20 minutes if no response. So care after the resuscitation. Once we are successful the resuscitation, counsel and advise the mother and family, teach the mother to check the breathing, warmth, and then contact the health care. If it is any abnormalities, they have to consult the doctors immediately. Encourage the breastfeeding as soon as possible, help the newborn more energy. So we have to tell the mother to initiate the breastfeeding as soon as possible, so it will help to maintain the proper the babies can maintain the proper energy. In addition, we have to explain the mother and family about the danger signs and seek help in need. Check the newborn hourly for at least 6 hours for breathing problem, chest introing, temperature, color, grunting, and then grasping. We have to monitor, give a normal care after the newborn. Maintain record about the resuscitation such as the steps of Apgar score. Care after the resuscitation, we have to monitor the Apgar score also. Do follow up. Ask the mother to bring the baby to follow up visit on 2 to 3rd day. And the next, need the referral situations, counsel and advice mother and the family about the resuscitation and then baby condition, about care needed by baby. Refer the baby to higher and well facilitated hospital. Encourage for the breastfeeding if baby is suck. Keep baby warm during the referral time and then throughout the way. Maintain the body temperature by KMC. I think people know about the KMC. KMC means kangaroo mother care. We have to keep the babies in the mother chest. So care including the keep resuscitation, continue the stimulate the baby, continue to mother breathing and color, keep the baby warm, continue oxygen during the transport if possible. During the transportation also we have to provide the oxygen support for the baby. Arrange the referral and then prepare the record and referrals per hospital protocol and then follow up visit. These are the including, and then condition if unsuccessful. If the baby's dead, mother and family about the resuscitation, we have to explain them. Care of dead body, clear. And if they are asking any question, we have to give the clear manner answer to the baby. Find out any wish to do the baby body. Talk family with. Ask the mother to return the postpartum visit within 3 weeks. Do all the necessary recording notification for the baby's birth, death, and the medical records we have to provide for the baby. Cleaning equipments and then supply the replacement appropriate place. It now we know study about the management. Here we are going to study about the nursing management. Here in during the birth asphyxia we have to examine the physical examination we have to done for the baby. So here first we are examine the respiratory system. If the baby is having the low Apgar score, breathing is low, irregular tachypnea, snoring, breathing nostrils, retractors, suprasternal, substernal cyanosis, baby does not breathe. These are the things we have to examine the respiratory system. In cardiovascular system, we have to monitor the optimal pulse, rapid or irregular pulse. Whether we have to check the whether the pulse here the baby is having the pulse rate is around 120 to 160, and then we have to check the cyanosis and then other hypoxia and pitting edema. Next, digestive system. Here the weak reflex we can assess. Small stomach capacity. Muscular system we have to assess about the decreased muscle tone, edema, weak reflexes. There are no lines on the soles on the feet. All of the form. We have to check the reflexes in the baby's muscles. And the next we have to do the if the baby is having the improving gas exchange by so we have to assess the breathing pattern. We have to position in the baby. If the baby is having removing the mucus in the respiratory pattern, we have to remove them with a clean gauze piece and then suction in the baby. Observe the condition carefully for changes in the respiration or color, providing the oxygen through the head of the box. And then TABC resuscitation. T may stand for the temperature. We have to maintain the temperature through the dry the baby quickly, remove wet linen and then place the baby under the radiant warmer. A stand for the airway. Establish an open airway by position the infant, suction mouth and nose. It have we have the record the ET tube. We have to intubation and then open the airway. C for the circulation. We have to do the chest circumference, chest compression. Preparation for the newborn for resuscitation. Preparation area or a place the resuscitation. The area should be near the labor room, free from draft, and the fan should be warmed. Preparing for the clean surface for resuscitation. The surface should be flat and then clean and dry with the covered the area. Preparation of equipments. The equipments required for the suction equipment, mucus extractor or gauze, electrical or manual suction catheter. Here we are using the 10 or 12 Frenches of suction French suction catheter here we are using. And then feeding tube size is 6 French, and then we can use the 20 ml of syringe. These are the equipments we have to keep near the baby before the resuscitations. In addition, we have to use the ventilator equipments like newborn sizes inflating bag, reservoir bag. The volume of bag is around 250 ml to 400 ml. Here we are using the face masks and then oxygen with the flow meter, tube, intubation set, laryngoscope, straight blade we have to use. Extra bulb and then batteries for laryngoscope, ET tube 2.5 mm to 3 mm, and then stillet and then seizure. These are the instruments we are used. And then medication like epinephrine, naloxone, sodium bicarbonate, normal saline, sterile water. And then next another than we have to use this shoulder roll, stethoscope, adhesive tape, gauze, 3-way stopcocks, clothes. These are the things we are using. And next preparation, designing the newborn need resuscitation. Thoroughly dry the stimulate the baby, rub all over the body, especially up and down, back. Here we are we bake the baby. Here we are giving the tactile stimulation, and then so position the baby, hyperextension position we have to do the baby, and then we have to keep the roller shoulder roll, keep under the baby's shoulder. And the next we have to initiate the clear the airway. Here pipe the baby's mouth and nose with a clean gauze or cloth or suction mouth and nose. We have to first initiate the suction on the first mouth, and then only we have to do the suction in nose. Suction only while pulling suction tube out. Introduce the suction up to 3 cm in each nostrils. So each nostril we have to introduce the suction tube in 3 cm. Okay, and then quickly assess the baby after positioning the baby airway clearance. If the baby is breathing without difficulty, no further resuscitation is needed. But if the baby is having difficulty in breathing or breathing like gasping, breathing or less 30 breath per minute without breathing difficulty, we have to do the breathing difficult. We have to do the chest crunching and the shallow regular breathing. Give oxygen. If the baby has no spontaneous breathing or still the baby is cyanosed, we have to start the ventilation with the amber bag or other available bag mask. So ventilation with the bag mask. For bag mask ventilation, use the baby size mask to cover the baby mouth and nose to ventilate. Hold the mask with one hand and ensure the airtight seal on seal using 1 or 2 fingers of the same hand to hold the chin and keep the head slightly extended. Squeeze the bag with the other hand using finger to only control the volume. Ventilate once or twice. Watch the chest rises. If the chest do not rise, check the baby position. Reposition the baby. The mask and try again until you get chest rise, and then each breathe. If necessary, we have to repeat this breathing. So here the picture shows how we have to hold this. In hospital, chest compression are provided by the thumb technique or 2 finger technique. Thumb technique Thumb technique, put the thumb on the lower third of the sternum, repeat the zippered process between the nipples, encircle your finger, and the finger technique to second finger lower the middle. So here the picture is showing two finger method and then thumb method. So we are giving the pump chest compression by this method. And then next, reducing the infection, assessing the general condition of the baby, perform the hand washing before and after the touching the baby, providing all morning care as well as eye and cord care, controlling the visitors, minimizing the invasive procedure, monitoring the signs of symptoms and infections. Monitoring the signs of infection, encourage the mother for exclusive breastfeeding. So we have to encourage the mother to give the breastfeeding. I think hope you all understand about the birth species. I think you are understand about the birth species and its management. I think you are enjoy this video. Bye. See you in next video. Thank you.